Good morning, everybody, and thank you for the introduction, and thank you to SAGES for allowing us to present our research today. There you go. Here are our disclosures. So enhanced recovery pathways have significantly improved outcomes in colorectal surgery, particularly with decreased length of stay, complications, and readmissions. At McGill, we introduced enhanced recovery following colorectal surgery in 2008, with our most recent iteration has a target length of stay of 2 to 3 days. Currently, we have a 66% success rate at discharging patients within the target length of stay. Currently, one of the major criteria for discharge within an enhanced recovery pathway is return of bowel function. However, recently there's been emerging studies that have demonstrated that discharge prior to return of full bowel function is safe in selected patients. Further, there's been emerging studies that have shown there can be early indicators of uncomplicated postoperative recovery, such as early tolerance of oral intake. Given the success of enhanced recovery pathways, as well as the emerging evidence supporting discharge prior to return of bowel function, as well as early indicators of uncomplicated postoperative recovery, we implemented an ambulatory colectomy protocol at McGill. In a recent study by our group, we demonstrated both the feasibility and safety of this protocol for same-day discharge. However, the study had a highly selected patient population. For example, the patients required access to a smartphone for remote follow-up. Despite the highly selective criteria, as a result of the highly selective criteria, a number of patients were excluded from the study. And of those patients, we still had a significant proportion of them that were discharged early. So we sought to evaluate the characteristics of these patients that were discharged early, as well as their outcomes, with the ultimate goal of attempting to expand our same-day discharge protocol. In order to expand a same-day discharge protocol or discharge more patients early within an established enhanced recovery pathway, we need to identify reliable predictors of uncomplicated postoperative recovery. In order to do this, our objectives were to first characterize the reasons for postoperative hospitalization, to determine the outcomes of those discharged early, and to identify predictors of successful early discharge in patients undergoing elective colorectal surgery. In order to do this, we conducted a retrospective review of adult patients at a single university-affiliated colorectal referral center undergoing elective laparoscopic colectomy or ileostomy reversal. We excluded patients that had new stomas and patients that underwent multivisceral resection. We also excluded patients that were enrolled in an ambulatory colectomy protocol. Patients were then grouped according to their length of stay in one of three groups. Patients that were discharged on postoperative day 1 were considered early discharge. Those discharged on postoperative days 2 to 3 were considered the ERAS target, and those discharged on postoperative day 4 and beyond were considered delayed discharge. Our primary outcome measures were 30-day emergency visits, readmissions, and complications, as well as reasons for inpatient stay. Overall, we had 497 patients included. 13% of patients were discharged early on postoperative day 1, 57% of patients were discharged within the target length of stay, and 30% of patients were considered delayed discharge. Interestingly, we found that early discharge was associated with lower ASA score, shorter operative time, intraoperative tap block, modality of postoperative analgesia, specifically a longer length of stay was associated with epidural and PCA use, and opioid usage. In terms of our primary outcomes, we found that the early discharge group had significantly fewer in-hospital complications. And interestingly, between the groups, there was no significant difference in 30-day emergency visits or complications, severity of those complications, median timing of emergency presentation, preventability of emergency visits, or 30-day readmissions. We then decided to look specifically at the early discharge group. 46% of those patients were discharged prior to the return of bowel function. Between the group that was discharged without return of bowel function and those that were, we found that there was no significant difference in 30-day emergency visits or complications, severity of complications, median timing to emergency visit, preventability of emergency visits, or 30-day readmissions. Next, we decided to evaluate the reasons why patients were remaining in hospital. What we found was that awaiting return to bowel function was the most common reasons why patients remained in hospital, more so prior to the implementation of our same-day discharge protocol. Following the implementation of the same-day discharge protocol, what we noticed was, although there was a significant decrease in the number of patients awaiting return to bowel function as their reason to stay in hospital, there was a significant increase in medical monitoring as the reason why patients stayed in hospital. To further evaluate predictors of length of stay, we performed a multinomial regression controlling for age, gender, procedure type, and comorbidity, and found that procedure time beyond the 75th percentile for a given procedure was associated with an increased length of stay. We also found that usage of an intraoperative TAP block was significantly associated with early discharge. Interestingly, studies in other contexts have found that day of surgery is associated with increased length of stay, as well as postoperative complications and mortality. And in our study, day of surgery was not associated with any of our primary outcomes. In conclusions, discharge on postoperative day 1 was not associated with increased emergency department use, complications, or readmissions. Full return of bowel function at discharge did not affect outcomes. And risk factors for increased length of stay were operative time, increased ASA score, and parenteral medication use. We also found that TAP blocks are strongly associated with decreased length of stay. And despite decreasing reliance on return of gastrointestinal function, surgeons are able to identify patients that require further hospitalization using other criteria. As a result, there may be potential to expand eligibility criteria for an ambulatory colectomy protocol or increase early discharge within an established enhanced recovery pathway. Thank you.